Hi, my name is Dr. Sachin Kukreja. I'm here today to talk about bariatric surgery. We're going to go through which operations we do, why we do them, and how they work. So let's get this started. Okay. A few disclosures as this is a CME event. I do receive money from Intuitive Surgical and Aesculap as a key opinion leader and as a speaker. So our goals for today hope to review the three main operations that are performed for obesity today. We're going to describe the metabolic and weight loss outcomes with each of these operations and then look at the long-term data. So if you go back to 1991, the criteria for bariatric surgery were first established by the NIH. And I think most of us don't necessarily firmly agree with these criteria, but they are what they are. And they basically state that if your BMI is over 40, you should be considered for bariatric surgery, or if your BMI is over 35 with comorbid conditions that may be associated with the obesity. Now, this has nothing to do with insurance coverage, Medicare coverage. This has just the NIH guidelines. And so different insurances have different policies and different criteria for covering bariatric surgery. Some of those comorbid conditions that they consider might be diabetes, blood pressure, sleep apnea, joint disease, fatty liver disease, pseudotumor cerebri. But overall, most payers, if they pay for bariatric surgery, will pay for BMI over 40 or over 35 with certain health conditions. There are some contraindications to bariatric surgery, which we should consider. For the most part, the contraindications are contraindications to any general anesthesia, but we do have to consider some special nuances. The first is extremes of age. We try not to operate on people who are either too young or too old. On the younger side of the spectrum, we don't want to affect bone metabolism significantly, expose someone to vitamin or nutritional problems. And so we have to be very cognizant when we're operating on young people what the long-term ramifications could be and make sure that we all understand how to avoid some of those things. With respect to our older patients, we just want to make sure they're certainly healthy enough for surgery. I've operated on someone as old as 84 and they did very well. The data shows that you can operate on people over the age of 65, provided that they have a good cardiovascular assessment before surgery, and their outcomes are on par with their younger counterparts. We try to avoid people with significant psychiatric illness, and depression and bipolar are not contraindications. However, unstable depression or unstable bipolar could be contraindications. We know that with bariatric surgery, because we are taking away some of the coping mechanisms and the stresses of surgery, that we could be exacerbating any underlying mental health issues. And so patients typically need to be mentally stable before bariatric surgery. We want to avoid our patients with advanced liver disease. Certainly a lot of our patients have fatty liver disease, and that's not a problem. But advanced liver disease to the point of cirrhosis is a concern. We want to make sure that we can get them through the operation without dealing with significant varices or other signs of portal hypertension. Additionally, if we do a gastric bypass and now they may have gastric varices, those may be outside of the intestinal circuit and difficult to identify endoscopically. So we want to avoid our cirrhotics. We try to avoid operating on people who are not ambulatory, so wheelchair-bound individuals are not good surgical candidates. Obviously, when people get really heavy, their joints may fail them. They may not be able to walk. They may be in desperate need of a joint replacement and can't get it because of their size. And that generally presents a problem. But we want our patients to be ambulatory. Our patients are typically walking within a few hours of waking up from anesthesia. We want to avoid people with active malignancy. People who are being actively cared for that malignancy. I think the exception might be something like prostate cancer or a fairly benign malignancy, and we're doing an operation to help improve their quality of life. Or even with prostate surgery, sometimes we do bariatrics so that when they get their prostate surgery, they have a better outcome in terms of functional status and continence. We also need to be aware of our patients' plans for pregnancy. After bariatrics, we want their weight to be stable for a period of time, typically about 6 months before we allow them to pursue pregnancy. We remind them that oral contraceptives may not be as effective during that time. And so we need to counsel them appropriately. And so generally we want our sleeve patients to be uh, avoiding pregnancy for 18 months and our bypasses for 24 months, duodenal switches for up to 30 months. And we have patients that come to us for PCOS related issues from their obesity, and we do bariatric surgery so they can get pregnant, but we do want their weight to be stable before they do get pregnant. IBD is a concern. Gastric IBD is very uncommon, and so doesn't present a problem for our sleeve patients. However, gastric bypass or duodenal switch patients, we want normal small bowel that we're operating on, and so we have to avoid those patients. And then our substance abusers, after bariatric surgery, they may turn to other illicits. Alcoholism goes up, etc. So someone who's already abusing alcohol or other illicit drugs could get worse after bariatric surgery. So we try to avoid operating on those individuals as well. There's a lot of misconceptions out there, and so I wanted to briefly touch on what we don't do anymore. So on the left here, in 2020, we don't do VBG, vertical banded gastroplasty. Unfortunately, a lot of patients and physicians still call this a gastric bypass. It's not a gastric bypass. They may say gastric stapling, and that may be what they're describing here. But a VBG involves a staple line and a band and is largely a restrictive operation. This operation didn't work and has fallen out of favor. We don't do open surgery anymore. Open gastric bypass is way in the past, thankfully. So we don't expose people to the morbidity and mortality of open surgery. Typically, our patients are done laparoscopically or robotically through incisions that within a few months are completely disappeared. And lastly, we don't do gastric bands. Major cities in the country may have one or two surgeons that are still placing lap bands, but very few bariatric surgeons still place lap bands with any degree of frequency. So in 2020, there are basically 3 operations that we're still doing. The first is here on the left. It's a sleeve gastrectomy. You can see that we're permanently removing a portion of stomach, and that stomach affects a lot of your hunger hormones, and leaving a long tubularized stomach available for food to go through. We're not dramatically affecting absorption by doing this. In the second operation, you can see a gastric bypass where we make a small gastric pouch at the top. That pouch is usually about 30 cc's or so. And then we have an intestinal rerouting beyond that. And the last operation is duodenal switch, and that's sort of a combination of the two. The stomach is sleeved and the small bowel is bypassed to give you the benefits of both of those operations. And so we're going to go through them with greater detail now. So in 2020, sleeve gastrectomy is the most popular operation performed in the United States. Somewhere between 55 and 60% of all bariatric operations performed in this country right now are sleeves. It hasn't really been around that long. First described in 1999 as part of a duodenal switch procedure. The idea was that duodenal switch was a very morbid operation being performed on very large patients that didn't tolerate anesthesia for a prolonged period of time, did not tolerate the bed positioning. And so what if they could just sleeve them, have them lose weight, and then come back and do a duodenal switch? And that's how sleeve became a standalone operation. Most of the papers for sleeve gastrectomy are, few years follow-up. There are a few papers with up to 10-year follow-up, but it's still, I think, a relatively new operation. There are some general surgeons that do this procedure. They don't do any other bariatric operations, but they do sleeves. It is technically easier than some of the alternatives, and complication ranges from 0.7 to 4%, depending on patient and technique and so forth. So I'm going to quickly show a video here of a sleeve gastrectomy happening. This is using the robotic approach. The left-handed instrument there you see grabbing the stomach, lifting the stomach up there, and ultimately we're going to take all these blood vessels along the greater curve of the stomach. to detach it from those attachments. And you can see this patient was a BMI of 75. She had a fairly large stomach overall. Once the stomach has been mobilized, as we say, the greater curve of the stomach is mobilized, we'll use a stapling device. There's a bougie in the stomach to help us size the stomach. And we'll use a stapling device here to remove that part of the stomach laterally that often produces much of the ghrelin that drives hunger. And we'll use 4 to 6 staplers here to ultimately get the stomach taken off. And you can see here, this was on the quicker side. Not all of them are this quick. There is a timer there, as this is one of our teaching videos. But the actual meat of the operation really took about 15 minutes. And so last, you can have the last part of the stomach there stapled off, and food will go down this channel here on the left. The weight loss here is actually quite good. It's probably a little bit less than gastric bypass in general. This was a brief review putting together a bunch of different papers, 46,000 operations in total reviewed. And you can see that from years 1 through 5, the weight loss ranges between 50 and 60% excess weight loss. There is, of course, a little bit of weight regain in there, but dramatically reduced from where they started. And so this is a favorite operation by many because of its technical ease and good outcomes. Nothing is perfect, of course. We do worry about leaks. Typically, when a leak happens, it happens at the very top of the stomach. That's the area under the highest pressure and with the poorest blood supply. These leaks can render fistulas, and those are often very difficult patients to take care of. The risk of a leak in most patients is between 1 in 400 and 1 in 500 patients. So not common, not frequent, but it can happen. Where the stomach takes a turn right here, that's the incisura. And although it doesn't happen often, you can get a stricture in that area that can create symptoms of obstruction. And lastly, reflux can happen after this operation. And reports vary widely, but I generally quote my patients that there's a 15% chance of having reflux, and some of those may be symptomatic, some of those may not be symptomatic, but 15% of reflux after sleeve gastrectomy. So gastric bypass has been around much longer. Originally described in 1966, the minimally invasive approach was described in 1994. And really within bariatric surgery and even obesity medicine, our understanding of metabolic surgery comes out of gastric bypass, but our knowledge is still quite basic overall. The early ideas were that this was a restrictive or malabsorptive procedure because you were making the stomach so small and you were bypassing a portion of the intestine. But ultimately, it was felt like patient outcomes and patient behaviors did not necessarily correlate to those restrictive or malabsorptive ideas. Patients were able to eat, they were able to eat reasonable number of calories, and the sizes of pouches didn't have an effect on weight loss, nor did the size of the roux limb. You know, you can take a pouch from 10 cc's to 30 cc's, and although that's a 200% difference, has no bearing on weight loss. You can take a roux limb and make it 75 centimeters or make it 150 centimeters of bowel, and that doesn't seem to have an effect on weight loss. And so these were discovered to be really neurohormonal operations that affect the way our body metabolizes food and calories and metabolism. And so that's where things have come from gastric bypass. Since its initial description in 1966, fundamentally the operation hasn't changed too much. The technical aspects have changed, technology has changed, our staplers have changed, but the goals of the operation are largely the same. And so most of the reviews show that this operation is actually safer than even cholecystectomy, because a lot of our patients who need their gallbladders out show up emergently in the operating or in the emergency room with no sort of preoperative workup, no cardiovascular assessment, et cetera. So these patients do overall quite well. The major components of this procedure would include a gastric pouch, division of the small bowel to create your roux limb that goes up to the stomach. This is your roux limb. The other side of that is your ligament detritus and your biliopancreatic limb, and so leaving you with a small bowel anastomosis. Bile comes down this way and mixes here, and then food and bile travel together. This is just a little video clip of the anastomosis, or the connection between the stomach and the small bowel. In my left hand, I'm holding the new stomach. This new stomach is about the size of a deck of cards. It's not terribly large. And again, here we are using the robotic platform. And then we're going to bring the small bowel to the upper abdomen. And you can see here, I'm basically mating the small bowel with the stomach using the stapler. The stomach is here on the left, the small bowel here on the right. And we're trying to get them even. And I like to make this connection roughly 2.5 centimeters across when that stapler fires. And now we're left with a hole where the stapler goes through. And so we close that hole as a matter of routine, for obvious reasons. So this operation typically takes about 45 minutes to an hour to complete. And so just sewing that hole shut, so that's nice and clean and watertight. And once this is all done, we'll obviously do a leak test to make sure it's okay. So this is a slide to show us what we know about our weight loss after this operation, from the big pioneers of this operation. And you can see here, we've got good follow-up. These are all studies with 9, 10, 12-year follow-up, which is very difficult to get in bariatrics, unfortunately. But our percentage excess weight loss beyond 10 years is really between 55 and 60% generally. And so post-op BMI is hovering generally in the low 30s after bariatrics for gastric bypass. And again, nothing is perfect. So the things we worry about are leaks. Leaks can happen about 1 in 200, 1 in 300 cases. Ulcers can happen in the gastric bypass. Typically when we see ulcers, they're in patients who are abusing NSAIDs or maybe smokers. And so I personally don't offer gastric bypass to patients who have a strong smoking history. You can get internal hernias, which are hernias of the small bowel on the inside, and the risk of that happening is about 1%. Very few patients end up getting underweight after gastric bypass, but it can happen. And we quote the risk of vitamin deficiencies to be around 4% if they're taking their vitamins properly. The most common things we worry about are things like iron and B12, and those are usually fairly readily addressed with replacements. The third major operation that we do in 2020 is our biliopancreatic diversion with duodenal switch. And I say that, we're doing this operation. If you look at national databases, somewhere around 1% of all bariatric operations are done as duodenal switch. But I do want to emphasize this because it is gaining a lot of traction. It has been modified slightly today to help minimize some of the nutritional problems that plagued it in the past. And as a revisional operation from sleeve gastrectomy, it really does have a lot of opportunity. And so this operation was initially the Scopenaro operation described by Nicholas Scopenaro. I've gone through various modifications, ultimately in 1998. So again, not terribly long ago, modified by Dr. Hess and Dr. Hess, father and son, to what we know as today's BPD-DS. Generally speaking, the indications are the same as other bariatric operations. Most surgeons reserve duodenal switch for the biggest of patients, so oftentimes a BMI over 50 or the worst of the diabetics. And so I've done DS on patients with A1Cs of 17 and seen the A1C come down to 5. But it definitely has the greatest weight loss, the greatest durability of weight loss, and the greatest diabetes benefit. When I do this operation on smaller patients under a BMI of 50, maybe I'm doing it for their diabetes or what have you, I just make my limbs a little bit longer to help offset the risk of nutritional problems. But nutritional problems, especially with your fat-soluble vitamins, can happen, and so follow-up is imperative. So here you can see on the right side of the screen is the duodenum that's been transected between the first and second portion of the duodenum. And here I have the small bowel that we're bringing up to that duodenum. And we are ultimately going to put the two together here. This is going to be a hand-sewn anastomosis where we're putting the two pieces of intestine together with sutures there. And so we're going to run those sutures all the way around to close this up, and then food will be able to travel through that anastomosis freely. So most reports of DS, and admittedly there aren't a lot of large series out there, report between 70 and 75% excess weight loss, a greater than 90% diabetes remission rate, generally a higher complication rate of surgery, increased risk of diarrhea or many bowel movements and steatorrhea, particularly with fatty foods. We do have to watch the fat-soluble vitamins because the common channel here can be of variable length. Some people will leave this as short as 75 centimeters, or up to 150, or even longer, up to 300. But the real liability here is the fat-soluble vitamins. So vitamin A, vitamin D, vitamin E, and vitamin K can be at risk. We want to make sure that they have the entire length of their colon, and so try to get a screening colonoscopy in all these people beforehand to ensure they don't have any colonic lesions that could render them without a portion of their colon down the road. This has been largely modified to where we have something called a SIPS or a SADI, and that operation, they don't do the second bowel anastomosis that's brought up here and brought up as a loop. And that's a modification that's been gaining a little bit of traction to help offset some of the nutritional problems as well. But we do know that as far as sleeves go, 20% of our sleeves may be revised within 7 years, and this is probably the best salvage operation if the indication is obesity after a sleeve. So one of the things I really would like to emphasize is that there's this perception out there. A lot of my patients' families will say this about their patient, about the patient is, oh, just eat less, exercise more. Surgery is just restrictive, so why don't you just restrict yourself and not have surgery, and you should have the same result. As obesity medicine specialists, we all know that it's not calories in and calories out. It's much more complicated than that. And so really want to underscore that the myth of surgery being restrictive or maybe malabsorptive even is not true. And so this slide helps to hopefully do that. This shows what happens to our gut hormones with bariatric surgery, and this goes through the different operations. Gastric band is LAGB there, Roux-en-Y gastric bypass, laparoscopic sleeve gastrectomy, and then BPD and DS. And goes through each of the hormones. GLP-1, first of all, is produced by the ileum and colon in response to meals. And so you probably know GLP-1 as pharmacotherapy for diabetes control. GLP-1 is known commercially as Victoza or Ozempic. It helps to increase the secretion of insulin in response to glucose intake, and actually has been linked to some beta cell growth. In addition, it suppresses the secretion of glucagon. It decreases gastric emptying, so you get a sense of fullness longer, and decreases GI motility. This is known as your ileal brake. And so as food is sort of stationary within the intestine, through this ileal brake mechanism, you tend to get a lot of the diabetes improvement as well as the weight loss improvement. GLP-1 also functions at the level of the central nervous system to induce satiety, and is suspected as probably one of the major etiologies for diabetes improvement in the days following bariatric surgery. We see our patients who come in the hospital on high dose insulin or insulin replacements, and they have an operation. Within 2 days, they're off those medications. Well, they haven't lost any weight. In fact, they're probably weight up because of all the fluids that they got in the hospital, but their sugars are way down, and GLP-1, I think, may be responsible for that. In fact, we know that people that don't have a big GLP-1 response, often, if they don't have a response early after surgery, are the ones that may regain their weight after some period of time with bariatric surgery. You also see that GLP-1 was not affected by gastric band, but with the the current modern day operations, GLP-1 goes up considerably. The next is the glucose-dependent insulinotropic polypeptide. It comes from the GIP, comes from the K cells of the duodenum and the proximal jejunum. Its secretion is enhanced by nutrients being in those parts of the intestines. It's also, like GLP-1, insulinotropic, but less powerful. It doesn't seem to have a significant effect on intestinal motility, and we don't really know what it does for diabetes quite as well as we do for GLP-1. For peptide YY, or peptide tyrosine, it's secreted by the L cells in the distal ileum and in the colon, and actually in the brain. Its secretion is proportional to the caloric density of the nutrients that one consumes, and it seems to inhibit gastric emptying and intestinal motility through the ileal brake mechanism. And so when someone has, in the normal state, a high dense calorie food, they get a big surge of peptide YY, and they feel fuller longer. Well, it seems like gastric bypass, maybe sleeve, and yes to switch may also have the same effect. So it also decreases your appetite at the level of the CNS. So we know that at baseline, obese individuals have lower fasting YY levels and lower meal stimulated YY levels. So patients with nominal increases in peptide YY after surgery seem to lose less weight in the long run. Oxyntomodulin is similar to GLP-1 in that it reduces GI motility and participates in the regulatory mechanism of glucose homeostasis, but they don't really know how its role differs from GLP-1 and peptide YY. CCK remains relatively elusive. It is a potent stimulator of satiety. It is normally secreted in the duodenum and jejunum, but what its effects are on weight loss remains poorly defined. And then ghrelin, or growth hormone releasing peptide, is made in the fundus of the stomach in smaller amounts elsewhere in the small bowel. It is the only orexigenic hormone that we're aware of, and it stimulates the hypothalamus. Obese patients are at decreased suppression of ghrelin after a meal, and ghrelin also inhibits secretion of insulin by unknown pathways. Lastly, ghrelin suppresses the insulin sensitizing hormone adenopennectin, negatively affecting glucose metabolism. So most of the data with ghrelin is mixed in weight loss. So really, if you want to look at the 4 operations here, you also see that gastric banding doesn't seem to have the same neurohormonal benefit that other operations have. So gastric banding is a restrictive procedure, and the other operations are not. So gastric banding is basically the equivalent of eating less, and the weight loss was just not great. And so gastric bypass sleeve and BPD-DS seem to have better neurohormonal benefit. Another myth that many people have is that surgical patients are miserable, and that's not true. So this was not the primary endpoint from this particular study, and I'm going to review this study in a moment. But this is based on a RAND 36 questionnaire looking at patients. In this particular study, patients were randomized, 50 patients are randomized to medical therapy, sleeve, or gastric bypass, so 50 in each arm, and they were followed over a period of ultimately 5 years, but this was from their 3-year follow-up. And you can see that this group of 150 patients was effectively the same on their RAND 36. However, after surgery and their 3-year follow-up, you can see that the people who had surgery, sleeve and gastric bypass, generally did better overall on this survey. And so their physical functioning was better, their social functioning was better, emotional well-being better, energy better, role limitations due to emotional problems better, general health and bodily pain were all better. Another myth out there is that we as bariatric surgeons are simply general surgeons, and I'm not sure that's true. I think it's important to remember that we're also endocrine surgeons. This is actually taken straight out of the American Diabetes Association standard of care guidelines. Now, their guidelines go back to 2016, saying exactly the same thing, but this was pulled out of the 2020 ADA standards of care guidelines. And the American Diabetes Association guidelines are that metabolic surgery, so not restrictive surgery, but metabolic surgery, should be recommended as an option to treat type 2 diabetes and screen surgical candidates with a BMI over 40 and in adults with a BMI over 35 who do not achieve durable weight loss and improvement in hyperglycemia with non-surgical methods. So what this says is if you have a diabetic with a BMI of 40 or higher, they should be sent for surgery. And if you can't get their sugars perfect and their BMI is over 35, they should be sent for surgery. And I think that this is often overlooked by a lot of physicians and patients too. Here on the red, This is actually them delving into even their low BMI recommendations. And so they say we should really be considering bariatric surgery with people with a BMI over 30, not even 35. So maybe the NIH criteria are a little bit too conservative. So this is really remarkable in my opinion. This was a 5-year randomized control trial. Patients were randomized, 50 patients were randomized to medical therapy, 50 were randomized to sleeve gastrectomy, and 50 were randomized to gastric bypass. And these patients were managed at the Cleveland Clinic and followed over time. This was a Stampede trial. And this is just really remarkable because you can imagine how hard it would be to randomize someone to surgical versus medical therapy. And then even at that, randomizing them to either a sleeve or gastric bypass. But they did it, and they did it very well. And so here you can see um, over time, this is their up to 5-year follow-up. Their sleeve and gastric bypass patients had the greatest drop in A1C, whereas their medical therapies, they were being managed by an aggressive endocrinologist and were able to bring their A1Cs down, but their A1Cs remained significantly higher outside of surgery. Here you can look at the number of diabetes medications that they were on before surgery, after surgery, and then depending on which surgery you're looking at. And so looking at baseline medical therapy, you have 53% of patients on insulin, you have 16% of people on multiple therapies. And what you see is that after the 5-year time period, they were able to bring some people off of their insulins, and they were able to reduce the number of therapies in some patients. But that really was greatly the improvements were much greater in the surgical arms for both sleeve and gastric bypass, to the point where on gastric bypass, 45 patients out of the 50 at the 5-year follow-up were not on any medical therapies at all for their diabetes. Comparable number was 25 out of 50, so 50% in the sleeve patients. And of course, this was a weight loss operation as well, not just an endocrine operation. So with respect to weight, the change in BMI from baseline in the medical therapy over a 5-year period was down about 2 points on their BMI, down much greater at its nadir. They were down 10 points on about 10 points in sleeve and bypass, and then they got a little bit of weight regain, but still well below their medical counterparts. And this is where they fragmented people above a BMI of 35 versus below a BMI of 35. And you can see again that even in low BMI patients, these are metabolic operations, and these patients seem to do very well from a metabolic perspective and a weight loss perspective on the low BMI category. We're also a little bit of neurosurgeons. When we operate on the GI tract, somehow the brain has its own response. And so while fasting, they looked at this. They know that our brains respond to food cues with different food stimulation, right? And so the brain response to food cues in women did not differ significantly despite BMI. After eating, brain activity quickly diminished in lean women, but remained elevated in women who were heavy. However, these changes could be reversed with bariatric surgery, and this was done by functional MRI. The other big myth is that surgical patients, I hear it all the time from patients' families especially, but that they can have bariatric surgery, but they're going to regain all of their weight anyway, so what's the point? And so if we look at some of the durability data, this is a study out of Greece that showed 5-year data. And on the left, you can see percentage excess weight loss. Did remarkable in the first year with 80% excess weight loss, and some of that trailed off. This was 203 patients with an average starting out BMI of 43. So sort of your average middle of the road patient was able to have 50% excess weight loss maintained at 5 years. And this is on par with most of the other data as well. And so there was a growing number of excess weight loss under 50 and reduced excess weight loss over 50% over that 5-year period, but the results were still remarkable. The same was seen for gastric bypass. So This was published back in 2015, and this was 300 patients from a single institution. Their mean pre-op BMI was 50 kilograms per meter squared, and their weight was 141 kilos with an average of 7-year follow-up. And you can see a third of the patients demonstrate weight regain greater than 25%. Regain 20% of the weight loss was basically the rule. So a regain, if you tell patients are going to lose 100 pounds, they should regain about 20 on average. Um, and early weight loss confers greater long-term weight loss, but not the amount of weight regain. And interestingly enough, the number one risk factor in this study for weight regain was depression. So again, underscoring the importance of the preoperative psychological evaluation. Now, this was interesting because this really, quite frankly, surprised me because we always really try to stress to our patients the importance of follow-up. But this was a 10-year paper out of University of Virginia where they actually had patients in a closed health system who were lost to follow-up, but they were able to do chart audits on them later on and figure out where they stood from a weight loss perspective. And even the patients who were lost to follow-up, when they circled back 10 years later and then traced back where their weight had been, those patients who were lost to follow-up effectively did the same from a weight loss perspective as those who were getting routine follow-up within the bariatric program. So when we are working with our patients and I'm seeing a new bariatric evaluation, I often will pull this up. And, bariatric surgery is highly scrutinized by the American College of Surgeons, and we have this called MSQIP, Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. And we can, using a database of almost 800,000 patients, because again, bariatric surgery is so well studied, we can look at this database, plug in what our patients' demographics would be, and actually show them based on this database what their outcomes will be. And so I'll show this, this is a sample patient, aged 40, female, BMI of 41, unknown race, Hispanic, with ASA3 as they all are because their BMI of 40, non-insulin dependent diabetic with high blood pressure. And you can see here the risk for them dying is way less than 1%, close to probably 1 in 1,000, 1 in 2,000, regardless of what operation we do. Complications here are as high as 8% with duodenal switch, as low as 3% with gastric bypass, but a lot of these complications are trivial. They may be use of narcotics for more than a few days, having to spend an extra night in the hospital, going on telemetry. So if you look at meaningful complications that we care about, the chance of a sleeve in this patient having a leak is around 1 in 300. A bypass is about 1 in 250 or so, and a duodenal switch around 1%. Chance of them being readmitted to the hospital is between 2 and 4%. And the chance of them needing any sort of intervention related to their surgery in the first 30 days is under 2%. So regardless of the operation that we pursue. So these operations are safe and they are very well researched. But if you look at this exact same patient and you follow her weight loss curves, red is for gastric sleeve, blue is for gastric bypass, yellow is for duodenal switch, you can see that this patient, she should lose about 60 pounds in the first year if she has a sleeve, about 75 pounds on average in the first year if she's a bypass, and about 93 pounds in the first year if she's a duodenal switch. And you can see that the bypass and the switch patients are still losing beyond 1 year. And this very nicely shows us what their weight loss would be over the first year, but our switch patients will keep losing, our bypass patients will keep losing. So we know that fundamentally people are living longer because of bariatric surgery. This is based on the Swedish obesity study subjects. It's a closed health system. All the data is tracked very nicely, and so it's a prospective controlled study involving 4,047 obese subjects, of which 2,010 underwent bariatric surgery, 2,037 received conventional treatment as a matched control group. Overall mortality was followed over an average of 10.9 years. At the time of analysis, the vital status or whether these patients were alive and doing well was known in all but 3 patients, so follow-up was outstanding. The average weight change in subjects, in control subject was less than plus or minus 2% during the follow-up. Maximum weight loss in the surgical groups was observed in the first 2 years, of course, and after 10 years, the weight loss is stabilized from baseline. So weight loss is certainly one outcome, but what about, are they simply still alive? And so in this study, 129 deaths were in the control group, 101 in the surgical group. Most common cause of death in both groups were MI and cancer, but both were lower in the surgical groups. And as a result, the conclusion is that bariatric surgery for severe obesity is associated with long-term weight loss and decreased mortality. And this has been verified by many other studies as well. You may be aware of the Edmonton obesity staging system. Unfortunately, a lot of patient referrals that we get are sitting on the stage 3 and 4, and those are obviously your higher risk patients. But obesity is a chronic disease, and it's a progressive disease. And so we really want to consider surgical options in our healthier patients before they get too sick. And so looking at our stage 2 and stage 3 patients is really where we want to be. Unfortunately, often, all too often, we have to turn away our stage 4 patients, and then the perception is that we don't want to operate, but really we want to help people while they're still able to be helped. So oftentimes, people are trying to figure out which operation might be for them, or maybe their doctors are talking to them about it, their primary care doctors are talking about it as well. I think if you're looking at a couple of different variables, age of the patient, if there's any concerns around vitamin compliance, reflux issues, smoking history, diabetes issues, planned pregnancy, prior bowel resections, IBD, and kidney transplant. This is sort of a chart that I keep in my head. Sleeve is generally the safest, most conservative operation for virtually any of these patients. We don't want to do aggressive operations on either the very young or very old. We don't want to worry about vitamins. So in people who might not be compliant, so we want to avoid doing duodenal switch or even bypass in some of those patients. Remembering that sleeves can create reflux. We want to avoid sleeves in people with significant reflux disease or maybe even Barrett's esophagus. Again, I avoid bypassing my strong smokers, and remembering that bypass and switch are the most effective for diabetes is important. Patients that are planning pregnancy in the next few years, we generally want to either do a sleeve or a bypass on. And if they've had significant bowel resections, we really have to understand what portions of bowel were taken, how much is remaining before committing to either bypass or switch. If IBD is a concern, sleeve is generally the safest bet. And for kidney transplant patients, and we do quite a few of those, we really want to favor sleeve or bypass because of the immunosuppression afterward. Duodenal switch may give them the best diabetes outcome, which could actually prolong their existing kidney function. Duodenal switch may give them the best weight loss outcome, which could prolong any existing kidney function. But unfortunately, the medications may not be absorbed effectively afterwards. And so considering bypass or sleeve for those patients is probably better. So before surgery, and Dr. Davis is going to talk about this in much greater detail later on, we want to make sure that they have a good cardiac evaluation, VTE evaluation. The biggest thing, one of the biggest things we worry about are blood clots after these operations. Treating sleep apnea, even using a CPAP for a few weeks before surgery, if they're otherwise going to be non-compliant with their CPAP, can be very helpful to decrease the likelihood they go to the ICU post-op. Making sure that they don't have significant hiatal hernias or reflux changes in their esophagus is important. And especially if we're talking about duodenal switch, a good colon evaluation is helpful. The mental health evaluation is key and should not be really skimped on. And then these are all tools, obviously. And so making sure that we have good dietary evaluations is important. Things to watch out for by the primary care doctor post-operatively. Most of these patients are managed by their surgeon early after surgery, and we should be picking up on all of these things. But oftentimes our patients are following with their primary care. They stop following up with us, not necessarily by our choice, usually by theirs. So I think it's important for the PCP to be aware of a few things. The diabetes improves dramatically, even during their preoperative diet. When we put them on liquid diets and they go into keto, we see their insulin requirements go way down. We stop their GLP-1s ahead of surgery. Metformin is a large pill and may need to be stopped. And if they have borderline kidney function, metformin can cause other issues when they have a little bit of an AKI after surgery. Their creatinine may go up by 0.1 or 0.2, and that just may be too much. ACE inhibitors may also be a problem with an AKI post-op, so being aware of that should they have a bump in their creatinine. Additionally, we do these operations laparoscopically, and so we induce pneumoperitoneum and we distend their abdomen. Patients on ACE inhibitors don't sometimes have hypotension during that event, and so we'll often stop their ACE inhibitors before surgery. We do try to institute pulmonary training preoperatively to make sure their lungs are optimized. Even a basic exercise regimen, just walking outside for a mile or two, can be very helpful. We make sure that they're using their CPAP before surgery, and if they have a poorly fitting mask, we try to get them a better mask before surgery. And then, of course, about 6 months after surgery, they may need to be refitted for their mask or even retested for their sleep apnea. Antidepressants should be continued to ensure stability through the change, and they should have good mental health follow-up as necessary. The dyslipidemia improvements that we see don't often happen right away. Typically, it takes a few months. So rechecking their lipid panels 3 to 6 months after surgery is important. Aspirin and ibuprofen can create ulcers in our bypass patients and increase bleeding risk, so we try to avoid them in those patients. Warfarin and other blood thinners. I think that this is an important point because a lot of these people have had DVTs previously. Warfarin is obviously the safest because you can check INRs and PT INRs, but that means you actually have to check it. And so a lot of patients have been transitioned to Xarelto, Pradaxa, whatever. And so we don't have much data around these drugs in bariatric patients. This was really the only thing I could find about where they're actually even absorbed. So sleeve shouldn't have too much bearing on this other than part of the stomach is being removed. But certainly gastric bypass and duodenal switch will affect how these medications are absorbed. And so I think if they need to be on these medications long term, I really do favor a transition to Coumadin in these patients just because we don't have data for how these medications work in bariatric patients otherwise. The next thing to consider is leak detection. We obviously check for leaks in the operating room. If a patient has a leak, typically it presents a week or 10 days after surgery, and these patients are not well, and they need a surgeon on board right away. So if a patient is not doing well and whatever not well means, 7 to 10 days after surgery, whether it's tachycardia, fevers, chills, nausea, vomiting, a leak should be ruled out. Considering nausea and vomiting, it's rare, but we can have those issues after surgery. Thiamine deficiency can happen very quickly, typically vomiting for just 3 or 4 days, and someone can classically develop thiamine deficiency. And this is one of the very few nutritional emergencies that we see in bariatrics. Thiamine, or vitamin B1, is a water-soluble vitamin absorbed in the jejunum and is a coenzyme for carbohydrate metabolism. So typically, if someone's having some hydration issues or some nausea issues, hydration issues, we'll have them hydrate with vitamin water, so they're getting a little extra thiamine. We actually keep thiamine in the office as an injection if they come in with issues. But severe thiamine deficiency can happen very quickly and can be tragic. So this thiamine deficiency, known as beriberi, is a spectrum of diseases and presentations: neuropsychiatric, cardiac, and GI. There are 4 clinical presentations of beriberi that may have ocular abnormalities, gait ataxia, mental status changes. Dry beriberi presents with seizures or numbness, pain, weakness of the extremities. Cardiovascular or wet beriberi presents with high output cardiac failure. And GI beriberi is delayed gastric emptying. And so I really want to emphasize that thiamine deficiency is tragic. The onus is on the surgeon, but I have seen malpractice cases where the primary care doctors are implicated as well. So if you know one thing, please remember to recognize thiamine deficiency early, treat it empirically. You don't need a thiamine level to treat thiamine deficiency. That lab will take weeks to come back, and by then that ship has sailed. And I should note that these neurologic problems may be permanent. So they're rare, but if this happens, it's tragic. So with that, I will close. I just want to thank the Dallas Obesity Society for this wonderful opportunity. Obesity is a disease. We should treat it. We're all in this together treating these patients. Surgery isn't for everybody, but it does uh, offer some significant benefit for select patients. There are significant treatment gaps in all of this, and I think that surgery needs to be considered along the spectrum of care for the treatment of obese patients and not as a last line therapy necessarily. So we treat this like any other disease with good follow-up and good follow-through. We have to work together with medicine and surgery. We can't treat cancer without the chemotherapy or cancer without the surgery. We have to use both. Things are changing, and I think that bariatric surgery has a growing place in our treatment of obese patients. And please think about it, and I'm happy to answer any questions. Much appreciated, and have a great day. Bye-bye.